All right, we're at the 12 o'clock hour, so I think we'll go ahead and get started. So let me start by first saying good afternoon and welcome to today's roundtable event titled Health Equity, Industry, Academia, Public Health, and Beyond. My name is Dr. Keith King, and I am an Associate Professor of Biology and Director of the Brody School of Medicine Center for Health Disparities here at East Carolina University. It is an honor and my pleasure to serve as the host and moderator for today's event, which was made possible through grant funds from Bristol Myers Squibb in partnership with Level Health Agency, Community Health Coalition, the University of Maryland School of Public Health, Wake Forest School of Medicine, and the North Carolina Department of Health and Human Services. Over recent years, especially since the start of the COVID-19 pandemic, discussions focused on health disparities and health equity have drastically increased. One might say the term health equity has become a buzzword lately. During the pandemic, we saw the disproportionate impact COVID-19 had, especially in communities of color. Furthermore, we observed firsthand how historical and political events can impact community trust that persists even during a global public health crisis. Overall health in the United States is declining. Recent data show that overall life expectancy across our country decreased by nearly 2.5 years between the years of 2019 and 2021. While health disparity statistics such as differences in life expectancy and quality of life, or differences in rates of disease or disease severity and death are often featured headlines, many of these disparities are driven by social and economic inequities. In order to achieve health equity, where every person has the opportunity to attain his or her full potential, and no one is disadvantaged from achieving this potential because of social position or other socially determined circumstances, a collective effort will be required. These efforts must address the complex nature of healthcare systems, education systems, public policy, community programs, and much more. Over the next 90 minutes, I'm excited to hear the diverse perspectives of our panelists regarding ways to work to eliminate health disparities and achieve health equity. So again, I welcome you all. At this time, we will have brief remarks from Michelle Calopi, VP of U.S. Cardiovascular and Established Brands at Bristol Myers Squibb. Michelle, the floor is yours.
There we go. Hopefully you can hear me now. So thank you. And on behalf of my colleagues at Bristol Myers Squibb, we're really excited to be a part of this panel. So my job is to just give maybe a little context in how we, as one partner in all of that work, Bristol Myers Squibb really sees what we do. And so as an inclusive and patient-centered biopharma company, our mission is to discover, develop, and deliver innovative medicine. And we believe that advancing health equity to what you spoke about, Keith, is really that assurance that everyone has a fair and just opportunity to achieve optimal health outcomes. And so we know that this is a part of what we need to do as a company, right? So it's changed how we think about our business, how we approach business, and our external partnerships. And we think, and we know that we can't do this alone, right? That it is really a team effort and will take effort across academia, community, industry to make sure we can drive meaningful change. And that's where we're focused. And the two things I wanted to highlight was, one, our business practices are changing. And so particularly in the space of cardiovascular disease, my team has worked on what we call the No Time to Wait campaign. So coming out of COVID, what we realized is that patients weren't coming in who should be coming in either for AFib or for VTE, for venothrombosis embolism. And so we developed a campaign in partnership with real physicians, with 15 physician and patient advocacy organizations to raise awareness about symptoms, that they need to seek treatment, that they should not wait, And we're continuing this campaign because, again, we think it's an important partnership, not just for industry, but for patients and clinicians to make sure that people seek treatment. And then the other thing we're thinking about is how we think about our external partnerships and making sure we're not just talking about them, but that we're actually investing in them, and, so to speak, putting our commitment forward. And so both Bristol Myers Squibb, which is who I represent, as well as the Bristol Squibb Foundation have committed $150 million each to make sure that we're thinking about what we can do. And the two places I want to highlight are health disparities, and so how do we work with communities to support those efforts, and then clinical trial diversity, not just in cardiovascular disease, but oncology, multiple disease areas, because we also know that that is clearly a place where we as a pharmaceutical company can play an important role. And to that point, we every year, we just announced in February of this year, grants to 24 nonprofit organizations that really then focus on how to train and mobilize community health communities, again, across, I represent cardiovascular disease, but across oncology, immunology, multiple disease areas, to how do we think about really helping to bolster the work that's going on in the communities, because that's where people do their outreach, that's how patients engage, how the communities engage. And then how can we help to increase care coordination, right, and making sure that those efforts are ethnically diverse. And we know that we are not the experts in that, right, that it's really important for us to work with our communities. So that's what the perspective I just wanted to share is how we are thinking about it, both as a company and as an industry. And we really look forward to the continued partnership with all of you to make sure that we can make a difference in patients' lives and ultimately improve health. So thank you for pulling this together and also giving us giving me a chance to say a few words at the start.
Thank you, Michelle. We greatly appreciate those words, and it's great to hear of Bristol Myers' efforts and commitment, especially when you talk about 150 to $300 million dedicated to this effort. So that is commendable, to say the least. And we hope that this virtual roundtable represents part of that process, or at least a start of that process and expanded programming addressing this critical area. So thank you for being here. I know you have to leave, so safe travels. And just thank you for this opportunity. So best wishes and good luck with all of the endeavors, and we hope to be a part of that. All right. So as we begin our introduction of our panelists, just a few housekeeping items. As time allows, we hope to address questions from the audience. So please feel free to place questions in the chat, and we will monitor those throughout the program. Also, we hope that all attendees will participate in a post-roundtable survey that will be distributed in the next few days. So as I go to share my screen and we begin to make introductions of our esteemed panel, hopefully everyone can now see my screen. All right, great. So again, it gives me great pleasure to welcome our four esteemed panelists today. For introductions, we will start, we'll go in alphabetical order. So for introductions, Ronnie, we'll start with you. Dr. Ronnie Bell, who joins us from Wake Forest School of Medicine. Dr. Bell.
Thank you, Dr. Keene, and thank you for this wonderful opportunity to be a part of this great panel and be a part of this discussion today. So I am currently in my role wearing two hats as a professor in the Department of Social Sciences and Health Policy in the Division of Public Health Sciences at the Wake Forest School of Medicine in Winston-Salem, North Carolina, but also serving as the Director of the Office of Cancer Health Equity and Associate Director for Community Outreach and Engagement for the Wake Forest Baptist Comprehensive Cancer Center. In my prior roles, I have in the health equity space, I for 10 years served as the director of the Maya Angelou Center for Health Equity here at Wake Forest. Also, since 2009, I have served as the chair of the North Carolina American Indian Health Board. So my ethnic heritage is I am American Indian. I'm an enrolled member of the Lumbee tribe here in Eastern North Carolina. I also had the very good fortune when I was at East Carolina from 2016 to 2020. I had the good fortune to serve as the associate director for the ECU Center for Health Disparities and got to work very closely with Dr. King in that role. Next slide. And during this time, I've had the opportunity to be a part of a number of initiatives trying to address areas of health disparities and health equity here in North Carolina, and particularly for the American Indian population. And these are some resources that I would invite you to take a look at. I was the co-chair of the Healthy North Carolina 2030 Task Force, which released our recommendations prior to COVID in early 2020. And part of our responsibility in releasing the 2030 recommendations for our state was that we focused specifically on the social determinants of health. And so we had 21 recommendations looking at health outcomes and health factors, specifically addressing some of the upstream factors that contribute to downstream health outcomes. I was also the guest editor for a special issue of the North Carolina Medical Journal in November of 2021, and the focus of that issue was on American Indian health in North Carolina. And one of the articles in that special issue is a very unique project called the Native Pathways to Health project, where in collaboration with the American Indian Center at UNC Chapel Hill, our North Carolina American Indian Health Board, and the Maya Angelou Center for Health Equity, we conducted a tribal health assessment looking at some of the specific concerns that the 8 tribes and 4 urban Indian centers in North Carolina had. We have the good fortune here in North Carolina of having the largest American Indian population in the eastern U.S. And so we try as best as we can to help address some of the concerns of our Native populations here in our state. So again, I just want to thank you for the invitation and looking forward to our discussion today.
Thank you, Dr. Bill.
Oh, sorry, I had one other slide. I did want to mention a recent initiative that started last year, a collaboration between the 3 comprehensive cancer centers here in North Carolina, Wake Forest, Duke, and UNC, called the Southeastern American Indian Cancer Health Equity Partnership, where we are focusing on the cancer needs of our American Indian populations here in North Carolina. So my apologies for that.
No problem. So thank you and welcome, Dr. Bill. Next, we have Dr. Ruth Phillips from the Community Health Coalition.
Good afternoon, everyone, and I'm so pleased to be here. I have the privilege of being on several committees and boards that allow me to speak for the community and be at the table. I currently serve as the Racial Equity Commissioner, Asian Well Durham board member, American Cancer Society, American Heart Association, the African American COVID-19 Task Force, all in effect to bring my voice to the table for the community. So I'm really excited to be there. We talk about life, which we listen, we investigate, we follow up and engage the community. So that's what we talk about when we talk about life for Community Health Coalition. Next slide. Community Health Coalition has been around for 30 years. Our focus was health equity before health equity was a buzzword. We focus on health disparities, prevention, education. We pivot a lot due to COVID-19. Our focus was getting people vaccinated and people informed about the importance of getting vaccinated. But we also know that those things that they needed to do, such as screenings, have decreased. Taking care of yourself, aside from heart disease and diabetes, all those things went to the back burner because of COVID-19, and we're seeing that deficit now. And so we do what we can for the community in Durham, outside rural areas, to get them back to where we need to go, back to the forefront. and hoping that we have these conversations so people can have the equity that they so deserve. So I'm glad to be a part of this conversation and part of this panel. Thank you.
Thank you. Thank you. We're happy to have you here and looking forward to the discussion. Next up, we have Dr. Stephen Thomas from the University of Maryland School of Public Health. Dr. Thomas, are you there?
I'm here. Yeah, we need the master of ceremony to unmute me. Thank you very much. It's an honor to be here. These polls behind me reflect the theme that I work from, which is authentic conversations. And one of the things that we do here at the University of Maryland School of Public Health, where I serve on the faculty in the Department of Health Policy and Management, is to translate the science of medicine and public health into culturally tailored, community-based interventions. And we've been able to do that in amazing ways. And I actually think, unfortunately, it's been a pandemic that has brought to the forefront the importance of building trust, building bridges, and building healthy communities. And you know what I've learned? You got to make your friends before you need them. And over the past decade, we've been spending time in our barbershops and salons to transform them into trusted information centers. And then the pandemic hits. We were focused on colorectal cancer, but the pandemic has provided a silver lining. And now our effort is part of a White House initiative, Shots at the Shop. And we have over 1,000 barbershops and salons across the country engaged in training and providing access to COVID vaccines. And I look forward to sharing some of those lessons in our panel today. And if time permits, I'm actually going to take this audience right into the neighborhood so you can actually meet some of the people being served with this innovative outreach strategy. And with that, I'm a professor in our Department of Health Policy and Management, and I direct the Maryland Center for Health Equity. Honored to be here.
Thank you, Dr. Thomas, and welcome. We're glad to have you. And last but not least, we have Mr. Cornell Wright from the North Carolina Department of Health and Human Services.
Thank you so much. Hope you can hear me. That is a nice slide you put together for me. Might have to steal it from my archives. So I'm so glad to be on here with my panelists. I won't hold you long because I may want to get into it, but I love being on an esteemed panel. And Dr. Thomas, we're definitely going to have to talk after this. One, I'm loving the hat. I think that's amazing. And then I was already messing with Ronnie via text, telling me he looked like a DJ with his headphones on. So we're gonna talk later. That's my brother. And then Dr. Ruth, you're always amazing. So it's going to be an amazing panel and great people, great energy. I am Cornell Wright, currently the Executive Director of the North Carolina Office of Minority Health and Health Disparities out of the Department of Human Services, where Mr. Cody Kinsley serves as our Secretary, Mr. Victor Armstrong serves as our Chief Health Equity Officer, and Ms. Angela Bryant serves as our Assistant Secretary for Equity and Inclusion. Around this time next week, I will be closing out my service, my 7-year tenure in this position, and will be moving to a new role with a national nonprofit called the Alliance for Healthier Generation, where I will become the first ever Chief Health Equity Officer for that nonprofit. And their work is connected to the Clinton Foundation and the National American Heart Association. So the work will never stop, and it just will have a more broader impact from my perspective. Been really involved in our community work, done some work here in North Carolina with our barber shop and beauty salon initiatives. So Dr. Thomas, I know we're definitely going to probably have some colleagues together like Dr. Laura Linan from UNC and others. Have also been widely connected to our COVID response. And yes, COVID still is a thing, regardless of what people say or think or may want to wish it away. It's still, still happening. And as a part of that work, one of the things that I'm most proud of is establishing around this time 2 years ago, formally establishing our historically marginalized population work group to really get the voice, seat, value, and understanding of community members at the table and having value with that voice, with that seat, and making sure that we could also set up other tables where they are leaders themselves in at those tables, and making sure that the voices of community doesn't go unheard. And so for 7 years, been blessed to be a part of this work in this position. But our organization is turning 30 years old this year. And so as Dr. Ruth mentioned, with her organization, we were doing this equity work before it was even coined that. And that's important because some of the leaders that started many of the organizations or many of the works that we've seen go on now, we're all connected at some point. And so glad that Dr. Bell mentioned the North Carolina Medical Journal, because there's so much goodness that comes out of those publications, especially here in North Carolina, that really highlights some of the work and some of the issues that we see going on in our state. And so the people who don't get a say often get left out of those conversations, but the work of people that we see on this panel and even beyond have really guided those conversations and those actions to make things more equitable. So thank you.
Thank you and welcome, Cornell, and congratulations on your new position. So I'm going to stop sharing my screen now and give everyone a chance to hear what they came here for, and that is this outstanding group of panelists. So to really set the stage and get a sneak peek into the complexity surrounding health equity and how people may have different perspectives about this topic, I want to start by asking our panelists, and in 1 minute or less, please, what do you consider as the two most significant health disparities or inequities, or what are the two biggest drivers or contributors to the health inequities that we see? And I'm going to call on Dr. Ruth first.
So the two biggest ones I put down, it was really easy for me, access and funding. I did it in less than a minute.
All right. Thank you. I like you follow rules well. I like that.
I follow rules.
Dr. Thomas, let's see if you can follow suit. What would your response be?
Well, I would say that, and if the time permits later, I have a short video that will actually show you what it looks like, but I think fundamentally it's all about trust. I mean, we can put the disease categories down and look how they've been siloed and look what's happening with long COVID. You got to have an endocrinologist, a cardiologist, a diabetologist, and someone who can deal with the hair loss. Those are all specialties that don't talk to one another. And so that system is broken. And I think that one of the things we have to recognize now is how the pandemic is an opportunity to rebuild trust in our community. So I would put trust as the number one thread we need to address to move the needle in health disparities.
All right. Cornell, what are your thoughts?
Well, they stole all my answers, so I'll jump in and say that one of the biggest things that I could lean on besides what was already mentioned is just the lack of understanding of what equity is and how it works. I think people oftentimes want to connect similar things as the same thing. Like we see that with equity and equality, but having a better understanding of how people and their work and their lives fit into helping to achieve and accomplish equity, I think is some of the biggest issues when you start thinking about issues like racism being a major factor to what we're seeing.
Right. And Dr. Bell, what are your thoughts?
Yeah, I just thinking about what we've gone through in this country in the last 2 years with the social justice movement that was sparked by the murder of George Floyd, along with the pandemic. I think it has brought to light so many of the issues in the healthcare and public health infrastructure in our country. And so, I would definitely say that, one of the most significant challenges we have is the systematic racism, the systematic or the infrastructure that has led to some of the social injustices that we see and that have been illuminated over the last 2 years. But also, I think just the challenges that we face in trying to set priorities for what is most important for us from a health perspective? Is it access? Is it cost? Is it quality? So all of those things sort of come into play as it relates to what we have seen over the last couple of years.
All right, all great answers. All great answers. So as we think about all of those factors, what are some immediate opportunities for small wins for us to move closer to achieving our goal of health equity? And I'll start with Dr. Thomas.
Well, I think the small wins are the little things. I mean, sometimes we try to boil the ocean. I think it's the little things, and it's the little acts of kindness. I spend when I'm out in the community making those initial contacts, at some of the community forums, the first 30, 45 minutes, I'm being told off. I'm being told off because of all the people who came before me. Now, they're glad to see a Black person from the university show up, but that just gets me in the door. And then they unload with all the people who came before, who poked and prodded and took samples and never told them what the results were. And here's what they say to me: and Dr. T, we're still sick. So this can't be more business as usual. So I think that it's the little things, the listening. It's the listening. We go in with all our data telling people, hey, you're in a food desert, you're in a high risk zone, you're in the red. And you know what? That's somebody's neighborhood. And we leave them with those details, which are important, but we don't stay for the solution. So I think we have to recognize that some of the things that we do in public health and our surveillance and our geo mapping and all the things that we're doing can further marginalize and stigmatize a neighborhood. Hey, if I'm a businessman, I want to open up a business, and I can look at that publicly available public health data and say, hey, this zip code has the highest concentration of diabetes in the state. If I open up there, I got some heavy long-term potential health issues I got to deal with this population. And so how might we recognize that the data we present to help guide us could be used by other sectors, private sectors, to actually avoid our neighborhoods? So I think we have to go in with solution. If we have a problem, we have to go in with solution. And here's the last thing I'll say. How about going into the community seeking their wisdom? Not going in to empower them. How about seeking their wisdom? And you know what, Dr. Keene, when we did that, you know what they said to us? They said, Dr. T, you got to break it down like you're talking to an 8th grader. And they're absolutely right. And as a result of that statement from one of our barbers, we're putting the COVID message, the COVID mitigation message, in the form of a graphic novel where they actually see themselves as characters in a cartoon book, but all the information is scientifically accurate, more accessible, less threatening, and a conversation that can occur in the barbershop that helps people set new social norms. In our shops right now, they're still putting their masks on. Black folk where we are are not playing. When you go into our barbershop, the sign says, to enter, you must wear a mask. I think that's a game changer. And we need to encourage them to use the safety of their clients as a business differentiator. You come to our shop, we'll keep you safe.
All right, awesome. So I do want to come back to one of the points you made. So if I forget, please remind me, especially the point you make about seeking community input and not necessarily having to have all the solutions or that savior feeling that we often, or concept that we often hear about. So I definitely hope to get around to that as part of the follow-up. Cornell, what are your thoughts? What are some immediate opportunities do you see for small wins to move closer to really achieving health equity?
First of all, you got to stop putting me behind Dr. Thomas, because we're gonna be sounding like this broken record together. We're talking about trusted, messaging and trustworthiness, and then accountability. Let me flip it a little bit from a statewide perspective here in North Carolina. I think what we don't do a good job at, and I was so going to start this off with talking about plain language. But he took that and then threw it at me. But what I think another issue that we're seeing is this whole issue of we have so many programs, right, at the state level that can help people, even beyond the state level, that touch, in different pockets that people just don't know about, right? And we don't do a good job in public health of promoting them. Let me give you just a window into the soul of who I used to be. I used to promote parties back in the day when in college, and I'm about 42, be 43 in August. So it was a different time. It's not what you see now, where like we had to go hand in hand doing handbills, learning people. It was a different process, but it was that kind of process that helped me understand how to connect to communities, right? So I use my hustle that I learned in hip hop to do public health. And so I say that because it becomes so important to understand the community or the people that you serve or your clients or your customer base, right? And you know what they want, you know what they don't want. But if you don't ever connect with them, you're never going to learn that. So if we don't ever figure out a way to give people the information and know about the resources that exist, the programs that they qualify for, that exist already, instead of having to try and reinvent a wheel, they're not going to flock to it. They're not going to know it exists, and they're not going to connect to it. So then your outcomes are going to be the same because you've not reached out to the people. And so we have to hold our leaders on all levels, whether it be local, state, regional, federal, international. We got to hold them accountable to really connecting to the people that need these resources from us. So I'll stop there because we got two other panelists that I'm sure want to weigh in.
Well, I do appreciate that. Dr. Bill, what are your thoughts on some short-term, immediate opportunities?
Well, I would definitely agree with Dr. Thomas that listening to the community, listening to their voice is important. But I would say another, and I'm not sure exactly how small this is, but I would say a definite opportunity we have is to get people together, policymakers who differ philosophically on health issues, and just getting them together and saying, let's have a discussion about what's really important to us as a community, as a county, as a city, as a state. I'm part of a group now, part of the North Carolina Leadership Forum, where we've had this year-long discussion with people across the political spectrum, and it's been really enlightening to see why people make decisions or come to conclusions about health and healthcare based on their own political philosophy. And so I would say I think it's just so very important that we kind of get out of our silo, get out of our shell, and just have some real discussions about the important health and healthcare issues we're facing right now.
Right, thank you. And Dr. Ruth.
You guys took everything, but I will also add, and I agree with all of you all, but the experience a person gets when they encounter someone for help or for health. Oftentimes that's a deterrent when you're asking for help, you feel belittled, or you feel insignificant, or you feel like you're wasting someone's time. So that connection and relationship with a healthcare provider or a public healthcare worker or anyone, really, that's a small win. Just taking the time. Dr. Thomas said it earlier, just listen. It goes a long way, but then follow up and then engage. You got to know what someone needs, and that's going into that community. That's boots on the ground. Be relentless about getting to know what that community needs and then how to address those issues. Not just say, oh, okay, thank you, and then leave, but then how are we going to help them? And you'd be surprised. The smallest thing could be a big win. It's really just connecting with people and knowing that they have a voice and that you have their best interest.
Yeah, and Dr. Ruth, you hit on something that I think really struck a chord with me and resonated. Oftentimes when we talk about investing in the community and resources, people think about multi-million, big bucks, but there are some small investments that can pay huge dividends. So I think as part of that investment in that, what do the community need, being strategic about how we invest our resources. And that's something I definitely hope we can talk about a little later on. But we started off talking about some small immediate wins or opportunities. If we wanted to think further down the road, what are some major opportunities for significant, let's say in the 3 to 5 year range? What are some opportunities in that regard? And Cornell, you get to go first this time today.
Yeah, I figured out the pattern. Once you started getting going, I said, okay, I got the pattern now. I'm gonna take us a place that many people forget about, and that's mentioning the richness that we have in our historically Black colleges and universities and our minority serving institutions. You have so many, people that come from areas, come from places with lived experience, and there's so much to gain just by connecting on that aspect. When Dr. Thomas earlier was talking about the work with the barbershops and beauty salons, and Ronnie was talking about working with the tribes, there's so many aspects of the work that we do in our communities that really speak to lived experience. And I think we tend to often forget about the richness that we have in those Black colleges and universities and minority serving institutions and what comes with that, especially in many cases where those universities and colleges are situated in the community, and then where the students come from. So getting them along those lines in that process is very similar to the work that we do when we connect back with our faith communities and getting to the heart of the community in many cases. But it's not just that the faith community is the only place we can go. There's so many different channels and avenues that we can touch on. And then how do we take that and make it a sustainable model that it's not just a one and done type of thing, but it's always consistent. So partnering a Wake Forest or partnering at ECU or partnering a UNC or a Duke with these other universities, when we've seen this happen in other cases, but we just have to have more consistency in doing this work, especially to achieve equity.
Yeah, and I love your point, Cornell, about sustainable models, and that's kind of something we're going to touch on in the next question. So I'm glad you kind of set us up for that next one. Dr. Bell, what would you say are some opportunities for some significant advances over the next 3 to 5 years?
He's muted.
Yeah.
All right, thank you. Yeah, I would say two areas. One is, investments in communities where we have all the sophisticated technology to identify, as Dr. Thomas mentioned, identifying areas where we have the highest levels of vulnerability, and we know why those vulnerabilities exist. And so I think there should be a process that should be put into place to help address those vulnerabilities, like access to healthy foods, access to quality health care, access to healthy and affordable living spaces. Again, that could take many years, but at least starting that process of identifying those areas and showing the overall benefit. That's a lot of times people they want to say, well, show me the economic benefit of this. Well, you can demonstrate that. There's been numerous studies now that have shown that if you address some of these issues, that it will have long-term benefit. I would say another area, and I see that Dr. Damon Tweedy is on, who is the author of the wonderful book Black Men in a White Coat. I think we need to continue to invest at a higher level in training the next generation of healthcare providers and public health, the public health leaders who come from communities that are the most vulnerable. So, underrepresented minority, rural populations, those populations that have been so impacted, and yet we know that people that come from those communities are more likely to go back to those communities, and they're more likely, ECU has proven this. The School of Medicine there at ECU, they train their own. They train mostly students from Eastern North Carolina, and they go back into the community. They do primary care, and they make a significant impact. So I would definitely say, that's an area where, 3 to 5 years down the road, we need to be making those investments in training that generation of healthcare providers and public health professionals.
Awesome. You bring up some great points, and I've made note of training diverse community workforce population that reflects the community. That's a point I want us to really spend a little bit more time on later on in the program. So I really do appreciate that. Dr. Ruth, what are your thoughts about some intermediate 3 to 5 year old, 3 to 5 year?
So for me, it's really going back to school and teaching our providers, our healthcare providers, our leaders about diversity and inclusion and equity, and making sure that it's not just like a one class, or it's a thread throughout the entire learning process. So I think we really have to unpack that and make sure that it's not just a one and done. It's an ongoing lesson that you have to learn, because when you get out of here, everyone's a great doctor, but you may not learn the lessons of understanding equity and how it impacts the patient engagement. So I think that's really important. I don't remember, it's been a long time since I've been in medical school, but I think we may have had a class or two, maybe, or a seminar on equity. I can't remember, but it needs to be just as important as learning anatomy, how to take care of the person, how to engage with an individual. The other thing I want to think about is, partnerships with those intentional partnerships with those organizations, intentional partnerships with large corporations, so we can address the needs of the community. There was one thing you were talking about, people who look like us, and I'll give you an example. Years ago, I was part of the African American Alzheimer's research study, and we were successful because we looked like the people we were serving. And when we went to another place, they were like, well, how'd you all get so many African-American people in your study? Because we couldn't. I'm like, because we were Black. We looked like the people we were serving. I know it was just really that simple. And we had a backing of HBCU that was proud, and they knew about it, and they trusted. And so therefore I was trusted. And so getting those connections and getting those people that look like the people in the community goes a long way. I hate to say it, I don't want to be so frank about it, but it has its value. It really does. And it should be a resource to be utilized more to make that impact in those communities.
Yeah, Dr. Ruth, and I think that the data would also show that, even if you look at healthcare, if you look at outcomes when you are treated by a clinician that is your same race or ethnicity, you have better outcomes. So I think that's a very, very valid point. That kind of piggybacks on what something Ronnie said earlier. So once we hear from Dr. Thomas, I want to circle back to that topic a little bit more. But Dr. Thomas, I'm going to turn it over to you. Give us some ideas about the interim, the 3 to 5, the intermediate opportunities for success.
Well, an amazing conversation. I want to comment on everything everyone said, but I don't have time to do that. So I wanted to say I concur. HBCUs, okay? How about Tuskegee? And how about Booker T? We're in April. It's National Minority Health Month. So let's give a salute to Booker T. Washington for the Negro Health Movement, 1915 to 1951. Okay, let's give a shout out to Caswell Evans, a dentist, public health professional who modernized and brought, Minority Health Month into what we have right now. And when you look back at Booker T's initiative called the Negro Health Improvement Week, that's how it started. And then it became the National Negro Health Movement. This is a history that we don't even teach our professionals. It's the longest sustained public health education campaign in the history of this country. And it came out of the Black community and launched by Booker T. Washington people. Come on. How about reenacting the National Negro Health Movement in the modern time that we have right now? They used the church revival as the framework. So that's one thing. In other words, our ancestors have left us a roadmap to save ourselves. How about using it? How about these certified community health workers? North Carolina. Here in Maryland, we've got our barbers and stylists going through training to become certified community health workers, but not taking them out of the shops where they're trusted and do their work and make them go to a hospital or a health department, but keep them where they are. And in doing that, I can't figure out how to get them reimbursed. Come on, Dr. Phillips, help me. I got certified community health workers helping these hospital systems do better care coordination.
Mhm.
And a community health worker can be reimbursed. There's a CMS code, but I can't figure out how to get that to happen. So these are structural issues we should address. And so here's what we learned through the pandemic. We've been doing Zoom town halls with our community, and nobody's getting a ticket because they parked in the wrong place. It has actually helped more engagement. How might we keep that going? How might we come up with our own podcasts? How might we deliver that message in the barbershops where they have a TV on every wall? And these are things that we can do. How about this thing right here? This smartphone. A lot of folks have dumb phones that only make a phone call. But the barbers and stylists and their clients, no matter what their income, even the poorest person, they got a better phone than I do. It's their TV. It's their everything. But they have not unleashed the health-related power on this phone. In the barbershops, we can have our own little genius bar and help people use these phones. If we're going to put life-saving vaccines at the end of the internet, we need to help grandma make sure that she knows how to use it, not make her feel like something's wrong with her because the iPad crash. And then last but not least, in the training of health professionals, we bring them into the barbershops and salons and we learn something, especially when they kept walking around with their computer bags and the barbers would say, why don't they put the bags down? And every 5 minutes go and looking out, seeing if their cars are still there. Their fear hung in the air like smoke. And we realized we had to have our health professionals go through orientation training. We call it building trust between minorities and researchers. We can't let all those other health professionals, Dr. Phillips, off the hook to say, oh, I can't go into that community because I'm not Hispanic, or I can't go into that community because and yet the majority of the workforce is you. You can't be left off the hook. So yeah, you got to get trained, and we call it on becoming a self-reflective health professional. And we've done these things, and it really makes a difference. And the last thing I'll say is that when these health professionals are in the shop, you know what they say? They say, this is why I became a doctor. They're finally connecting, and nobody's saying, hey, you got 15 minutes, you got to get out, your appointment's over. They love it. But then they said to me, Dr. T, they said, this is our social medicine month. They get 1 month. And so I want to make sure that month we're able to immersion. We call it urban immersion, where the health professionals are immersed in the community, in a barbershop and salon, and they actually operate there as health educators to get oriented. I think these are things right at our fingertips right now.
I think that's great, Dr. Thomas. And that makes me go back to the point we talked about earlier. So from the other panelists, Dr. Thomas talks about the immersion process, but what do you see as opportunities to address that or overcome those fears, or how do we eliminate that, what I call helicopter practice, where, the academicians or clinicians or researchers are in the community just during the duration of their funded project, and once the project is over, they disappear. How do we plan? How do we prepare? How do we activate this sustainability? And I open that up to the panel. This is something just in addition to that as a follow-up. So whoever wants to volunteer to go first, go for it.
Well, I think calling it out helps. Calling it out, you got to call it out. Say, this is no longer acceptable. This is unethical. Okay. And then say to the institutions that the institution has a responsibility to put the infrastructure in place so that our young scholars are not faced with, having to create the relationships all over again. So that's what happens. Everyone's doing it in a serial way rather than an institutional commitment to maintain the infrastructure for community engagement. It's in this context that our Centers for Health Equity, where they exist, can play that role if they're at the university, and our state offices of minority health can help do that as well. But the community needs to demand and say, we are no longer going to let you poke, prod, take samples, and never let us know the outcome. And we are still sick. You cannot build your career on our suffering. And they got to hear that all the way to the president's office at our institutions. Hey, after George Floyd and everything, everybody wants to be an anti-racist society and all this kind of anti-racist organization. Let's hold some feet to the fire and make sure that there's infrastructure in place to ensure that you can make the change.
I agree with that. Cornell, I think you were going to say something.
No, and I'm loving that he said that, because it goes back to a couple of things that have been said already. And I know Ronnie talked about policy, and then was mentioned about accountability. And, adding those things as part of the component of the research is important. So put in the policies and accountability to show, after the research is done or after the studies are conducted, that you got to go back and share the information and talk about what Dr. Thomas is talking about, building those sustainable partnerships of trust and trustworthiness within organizations, so you don't have to reinvent the wheel each time. And I think that's largely important and not being done. We got a colleague who used to be in North Carolina who moved to California, Dr. Lori Carter Edwards, who was working up until she left here on like a community bill of rights of sorts for communities to know what their power is. And when we talk about racism in this context, usually we're talking about systems of unshared power. And so we got to figure out how to change that power dynamic and shift that into, how can communities see themselves in the process? How can they see themselves in the data? And Dr. Bell would be first to tell you that here in North Carolina, our American Indian communities definitely, are asking to see more of themselves in the data, especially what's being captured and not captured in terms of tribal affiliation in connection to the data. We can tell you, we've got American Indians, here and there, but we can't tell you, specifically if those numbers add up, properly. And we can't even break it down, if what we're seeing when we're looking at diabetes, heart conditions, and other issues that may be chronic issues, how that breaks down by each tribal affiliation, even though we have state and federally recognized tribes and then unrecognized tribes here in North Carolina. And that to me is a part of the problem. So adding that to our policies and our accountability processes would be a huge thing to add to that.
And I would just add to what Cornell said that at least 2 of our 8 tribes in North Carolina have a formal process of approving research. And my tribe, the Lumbee tribe, if I want to do research in the Lumbee community, I have to first present my research idea to the Tribal Health Committee, and then the Tribal Health Committee then presents that to the full Tribal Council for a resolution. And so that, I think, is a way in which a lot of, particularly for American Indian communities, they are taking back that authority where, they so many times, researchers have come from the institutions and done research and then left, and there's really no benefit for the tribes. And so I'd say utilizing a process like that, where there is a formal structure in place, where you not only have to get a tribal approval for your project, but also, what is the ultimate benefit to the tribe? What are you hiring people in the community to work on this study? Do you have people at the investigator level who are co-collaborators on your project? Do you have a dissemination plan in place for when the study's done, where you communicate the findings of the study to the community? So all of those things, I think, are important.
Absolutely, I would agree. Dr. Ruth, did you want to add to that?
Yeah, I'm just going to echo everything that everyone said, but transparency is so important. Community Health Coalition works with Duke on a couple projects, the main thing is that whatever the outcome is, we want to know as a community. We want to share that information, see how my being a part of it impacts it. So definitely transparency, accountability, just all those things really help build the trust. Also, again, in those areas that may have not had that trust in the past. So just going back, providing that information, giving that transparency, and knowing that what I've done has made a difference. People want to know, and that's so helpful.
Yeah, I would agree. So on a related note, but slightly different, we talk about the diverse workforce and reflecting the communities you serve. For me, as a genetics researcher, I have a great appreciation and desire to include more diverse participants in my research studies. So that need for representation and inclusion, especially in terms of diversity, is very important to me in my research agenda. So how do we improve some of our inclusive practices that can advance the increased participation in research and clinical trials? And Ronnie, I'm thinking about you a little bit here because we often hear about, well, we all know about Tuskegee, and we hear about research misconduct and lack of trust in Native American populations. But how do we really shift and build that trust that will enable us to truly get representation in these research and clinical trial studies, so the results from those studies can benefit diverse communities?
I would say so. Definitely, some of the things I mentioned earlier, ensuring that there is involvement at the administrative level for tribes in the decisions related to the study, the implementation of the study, of the protocol, as well as the dissemination of the study findings, and ensuring that the researchers communicate the value of the research to the community. But also, I would say that I think it's important to ensure that there is a process that in place that goes in the direction of, that you're not at the door the day before your grants due asking for a letter of support, that there is months and months of engagement, uh, understanding the community, understanding the culture, understanding some of that history around the times where there's been exploitation of tribal communities and communities of color in the research experience. And so, that oftentimes is just not taught. It's not part of the discussion. And so, having an understanding of why tribal communities or community of color, why they have this reaction when people come to their door and say, hey, I want to do this research study. There's a long history there, and that needs to be understood.
Yeah, and I enjoy one of the comments that one of our attendees wrote in the chat. We must build capacity within our communities to meet their health needs and no longer treat our community members as experiments. Cornell, you and I were just joking about that just before the call, so that's so spot on. Did anyone else want to comment about the need and the approach to have more diversity in our research and clinical trials and things of that nature? I know Dr. Ruth, you brought it up earlier, so.
Right. So for me, and I am straight no chaser, so forgive me. I look at research as a person who's did you wrong. You may forgive that person, and you may not ever, but they will never forget. So just know when we go into research, we aren't going to forget the things that happen, but we have to choose whether I trust you enough now to move forward, or I'm going to say, you know what, I'm done with you. And so that's really where we are when it comes to research. So we have to understand that is a long history of building trust. You're going to always have to continually build trust. It's not going to stop, because that person will never, ever forget. And so always remember that it's a really delicate line, and you have to do all that you can to ensure that you're trustworthy. because that person, again, is never going to forget what happened in the past. And they will always kind of remember it can always happen in the future. And that's in the back of their mind. So think about that when you're approaching getting people to engage in research. Understand that's where they are, and, and give them what they need. If it's transparency, make sure you have it. If it's accountability, make sure you bring it. But always know that that is the undercurrent in which you're doing your work.
You know, I think the issue of trustworthiness needs to be emphasized. And I say that because when we're out in the community, we get a lot of, you know, media coverage of the barbershop. It looks so simple. It looks so simple. And people say, oh, I drive by barbershops. Let me just stop in. And what we found, Keith, is that people came behind us, putting their literature in our queues, thinking that, and the barber saying, oh, they're from the university. Dr. T sent you. It's a unit that never even called me. Disrespectful.
Mm.
You know, competition, not cooperation, co-option. So one of the things that we've learned is, and someone says to me, oh, Dr. Thomas, you say we got to go through you to get to the community? And in the early days, Dr. Phillips, I said, no, I'm not saying that. And then I talked to somebody from New York City. They said, Dr. T, you've been, what, a decade tilling the ground, getting all the rocks out? Yeah, you got to come to us. You ain't going to mess this up again. And COVID is our pivot. You know what the people are saying? They're saying, Dr. T, why we watched you try to get the health systems to come in when we were dealing with colon cancer and diabetes, and sometimes they wouldn't even return your call. Now the phone's ringing off the hook. Can we bring our mobile unit to you? Can we bring our vaccines out? And here's what they said to me, Keith. Hey, Dr. T, are they going to give us the jab and leave us with the diabetes and the obesity? I tried to explain to them, and then I listened and I heard what they're saying. If they just give us the jab, that means we can't infect folk when we're out shopping or in our low wage jobs, but they don't really care about us. And I think if we let that happen, we will have missed the moment to rebuild the relationships with our community. And so I say we need to lead with service. And I know we're in these academic institutions, and a lot of the things that they see us do out in the community, they want to label that as service, as less than. We have found that the way to improve the diversity of your clinical trials is you lead through service. Now, our medical people know this, but they don't want to talk about the fact that they use the therapeutic misconception. Where are they doing their recruitment? In the hospital. People come into the hospital not to join a study, come in the hospital for care. So let's lead with service. And what we did, and I'll leave with this, we took our Xfinity basketball arena and we turned it into a 120 chair emergency dental clinic with volunteer dentists, not students, that went from cleaning to oral surgery. We served 1,000 people in 2 days. They slept outside overnight. If you've ever had a toothache, you know what I'm talking about. Meet them at their need. And from that point, guess what? They're ready. They're ready for, can you help me with this? Or, can you help me with that? I had a whole list of cardiovascular issues, but the barber said, I got varicose veins. Can you help me with that? So we may go on with our data to say you're at increased risk for whatever the disease. And they come back with something that's not on your list. Start with their list. That's how we rebuild the trust.
Oh, that's great. That's great. And Cornell, I see you wrote in the chat, build, earn, and sustain trust. Anything else you want to add to that?
Look, I'm mad at the three panelists. Look, I'm going to tell you why. I'm gonna need a neck brace because my head just keeps bobbing up and down. Yes, because y'all are preaching, right? Like y'all are saying everything I want other people to understand that is important, that are in leadership roles. And this is the problem. The four of us, the five of us, however many people are on here, we get this. We understand it. It's the people that don't look like us that have power influence and to be able to make higher level decisions that aren't listening. Oh my gosh. Like we could we hadn't even talked about the environmental issues that we face, right? You know, I know Crystal Dixon's up here, ECU alum, who makes it her work to make sure that our people understand the brevity, the breadth and the depth of the issues that we see in our environmental inequities, right? And so we hadn't even started talking about that. We're talking about simple stuff. I told the people at the state before I left, I said, look, we are at a golden crossroads right here. And if you want me to take it hip hop, we at a platinum level crossroads here, right? Where we can really have so much trust that's earned, built, and sustained by giving people what they want while we're out here trying to give people what they don't want. So as you're out here trying to give people a vaccine, you know, how can we help them get food on their table, have sustainable, you know, and healthy housing, as Ronnie was talking about? How do we connect them to services like, you know, HIV and chronic disease services and maternal equity services that already exist? Plug it in. Use our community health workers. When we had the CICT staff, use them, like connect them. And I love the point of making the barbers and stylists, you know, certified community health workers. They're already there. You know, the biggest complaint we got from our barbers and stylists, Dr. Thomas? They said, how come we weren't deemed essential workers in the pandemic?
Yes, absolutely.
But nobody want to listen to them. Okay, let me stop talking because we got to do this. We got to keep doing this roundtable and making sure that like people hear it, people feel it, and people have a voice, you know, as a part of this too. Because like I said, when we even talk about the environmental issues, I'm a victim of environmental inequity as being in a military family here in North Carolina, being a victim of water contamination at Camp Lejeune. And we got to talk about this stuff. Because if we don't, and you know, and Ronnie it will tell you, even down east, like where the Lumbee are housed, just that whole issue of them dealing, people from that area still dealing with the hurricanes before the pandemic, and how that, you know, plays a huge part on our health and well-being. You know, looking down in southeastern North Carolina in the Sand Hills, and it's not just us, but those are areas that we know about. If we're not talking about it, if we're not bringing light to it, I love our entertainers, I love our rappers, I love our you know, industry folks, but I could give a, well, I'm on vacation, I ain't gonna cuss, but I could, no, I will cuss. I could give a damn about you buying out the bar. Put something on these people's student loans, on their light bill, on their housing and their water. Like that's what's important to people. And if you meet those needs, they'll follow you anywhere. They'll run through a brick wall for you.
Yes.
But if we're not meeting basic life needs, what are we doing this for? Just so we can look good on a press release? All right, let me stop.
So Cornell, I'm going to step in because I think that's a great transition to one of our other questions. How can we be more intentional about forming these partnerships between key stakeholders, whether it's the wealthy, whether it's academia, healthcare, community, state, government agencies? How can we be more intentional to help modify either existing or create new policies that are really going to make a difference? And I'll let you start, Cornell. I'll let you continue on your.
Well, no, I think it's been said over and over again. You got to involve the people, right? And it's not just, you know, this. Let's put them on a shelf. Let's put them on a platform and exploit them. It's really getting in, getting your hands dirty. I think that's the bigger problem. Dr. Thomas and others alluded to it. People don't want to go into the community because when you get past that surface level of community, when you feel a little twinge in your stomach, like, you know, should I be here at this time of day or this time of night? That's when you're starting to feel like you're really in community, not this surface level thing that like, oh, you know, we held hands, we sang Kumbaya, and we went home. You know, no, that's not community. When you really get deep into it, where you feel a little unsafe, but you know that you're still safe because, you know, your people got your back.
Yes.
You in community then. And we got to get to that level consistently and make sure that we're making a difference. I'll stop because I know I've been talking for a while, but y'all go ahead and take it.
And you know, Cornell, one of the strategies that we had in bringing the cancer center into the barbershops was around prostate cancer screening. And we had to get some volunteers, and it happened to be two white nurses who volunteered. And we're in the heart of the Black community, the kind of place where they would say, "Why are these white people here?" That's where we were. Okay. On the day when we would do the screening, we would have prostate cancer survivors hang out in the barbershop and just be there. And in the shop, we put money to renovate the space so they had privacy to meet state guidelines for screening. We did PSA blood draws and rectal digital exams in the barbershop. And the barbershop was called Big Tom's Full Service. Is that not full service?
Mm-hmm.
Now, here's the thing that's not in the literature. It was a success. And we asked the men, what made it work? And here's what they told us. Well, a woman's hands are smaller than a man's hands. I thought that was interesting. And I'm not likely to be sitting next to her in the club tonight or in church on Sunday. The privacy, because it was the two white nurses, gave them some anonymity. And what was it about the nurses? They were fearless. They were like on a mission. And we had to constrain them a little. They got so comfortable, they were running across the street to the jitneys and the bars, bringing people into the barbershop. And we said, no, no, no. But they said, oh, they're with Big Tom. And just like you said, Keith, they're with Big Tom. They're in a bubble of safety. They're with Big Tom. My point is, we can do that in a barbershop. It's simply getting our hospital systems to get out of the convenience of being where they are. And if we can do all this, turning a big ship around and for COVID, if we can do all this warp speed for COVID, how about some warp speed community engagement? You know what they did, Dr. Wright, for warp speed? They paid the companies in advance. They paid them in advance. And before they even had a product. And then they paid them for the market share. How about a warp speed for community engagement, Dr. Keene? Let's get that attitude.
I love it. I love it. Dr. Ruth or Ronnie, do either of you want to add to that?
I was just going to go back to what Cornell had stated about being in the community and doing service. I know in Dr. Thompson, taking, going in the community and doing several things at one time. So we use COVID-19 to our advantage.
Mm-hmm.
We come get your vaccination. We're doing colon screenings. Oh, let's take your blood pressure. Do you need a box of food to go? I mean, all of this is in one setting, in one place. So we're going to tackle all the needs that we can in one location at one time. And that takes communication with different community organizations where we pull together. And I don't want to see that go, because we can see all the work that we can do. So definitely utilizing the services, pulling together, getting people where they are, do all that you can in that moment while you have the audience, and get it done. That's what we've been doing. I think we've been doing it pretty well. So you can walk out with a piece of chicken and get your vaccine and get a colon screening test on the way out, and your blood pressure is checked and okay. And we just do it, and it's right in the community,
And
right in the heart.
Dr. Ruth, when they, the hospitals say, okay, we'll bring our mobile unit, but they're not the ones organizing it. When we organize it as the wellness warriors, you feel like you're coming to a party. We got a DJ, we got the barbecue going, and inside we got the health professionals. Ask them all your crazy questions about the COVID virus. And you know what? People came hesitant, Dr. Ruth. They came hesitant, and they left hesitant, but vaccinated. We didn't have to change their worldview. We didn't have to change their political affiliation. We just treated them with
I will
dignity
say,
and
for the
respect.
vaccinations, we had doctors out there that looked like the community talk about the importance of getting vaccinated. And that was so important, because we had people there that were on the fence, wasn't sure. But after talking to someone in person, someone that looked like someone from the community, they were able to make that decision to go ahead and get vaccinated. So that's so important. It was so important.
You know what part of the problem has been? It's been the approach, right?
Yes.
We've been so confrontational as public health practitioners, like to push people to get vaccinated instead of having like hand holding conversations and say, tell me what your issues are. Like, tell me what your misgivings are. Let's talk about it. And I've seen that approach. I've used that approach more myself. And I tell people from the jump, look, I work for the state, but if you can get vaccinated, let me tell you why this could be helpful. And then let me also tell you why speaking to a medical professional about your personal situation is also key, because I also have family members and people I know that can't get vaccinated due to certain circumstances. So I'm not telling you like I'm trying to push a drug on you, but I am trying to push life and healing and well-being. And when you go with that approach, it's a different conversation. It's not confrontational, and people are willing to listen. Not saying that they're going to accept everything you say, but they're willing to at least have that conversation if you are.
No shame, no blame. No shame, no blame. And if you trust the community, that when you give them the information they need in a format they can absorb, they will naturally gravitate towards saving their own lives. That's the faith that we go into the community with. And that's exactly what we're seeing happen.
And I think a lot of times we are at fault because we get so siloed in the way we think about health and wellness. And so, as Dr. Phillips said, a lot of what we know about cancer, diabetes, heart disease, stroke, there's underlying causes that contribute to all of those. And so why are we just restricting ourselves? The cancer people come in and they do this, the heart disease people come. Let's work together and let's try to address some of those common issues that we know smoking affects your risk for cancer, it affects your risk for heart disease and stroke. And so it's baffling that we are so inefficient in the way we address the community by sort of putting these blinders on and addressing it just to satisfy our one particular domain.
So, Ronnie, and I know the North Carolinians, they love North Carolina. I get it, and I love Maryland. So how might we share best practices? Here in the state of Maryland, we pass legislation on health and all policies, where the agency secretaries, transportation, education, you name it, have to be at the table and say, how does this transportation policy impact health, using the environmental assessment framework as a strategy? In the state of Maryland, this past legislative session, we passed a law in the state of Maryland that to renew your medical license in 2020, you have to complete implicit bias training. Now, that's one thing to say you have to do it. Now, the content makes a difference. If it's just going to be go online, do a lecture and take a quiz, we know that ain't it. But that heart and soul of that legislation is designed to do what all of us in this space have been talking about. We've got to get the system and the majority of the health workers in that system who don't look like us to actually be accountable for the structures that continue to disadvantage our communities. And so in the state of Maryland, we're working to make sure that the implicit bias training is authentic and real. Okay, so just passing the law is not enough. We've got to hold things accountable. But I'd love to share that legislation with my friends in North Carolina.
Well, and I think that's a good idea. And I put a little message in the chat saying I blame AAU culture. And let me explain what I'm saying is that back in the day, before I was born, our people, we focused on, being well at a lot of different things at one time. Whereas now people have become more specialized in their approaches throughout society. And it seems like we can't blend. And that's where these silos come up in our work and our lives. And we got to be able to be connected on all sides. And so, and I think it was Dr. Ruth, and I'm gonna give her credit for it. Even if she didn't say it, I know somebody said it today about making sure that we move beyond just DEI. And I think one of the things that the organization I'm going to next week, starting next week and really starting May 2nd, is that their focus is on JEDI, which has the DEI aspects, but also includes justice. And I think if we can really start to hone in on the justice with the DEI, it's going to really change how we really look at how we do our policies, our procedures, and our practices across the board. So I just wanted to add that component.
Hey, Dr. Wright, if I could, and Keith,
And I'm just Mister. I'm not Doctor.
oh, okay. We can all get the PhDs after the work we've done. But you mentioned what you just mentioned was so important on the DEI and the ethics and justice. So here's from Tuskegee. In the aftermath of the U.S. Public Health Service syphilis study done at Tuskegee, they held congressional hearings. And out of those congressional hearings came the Belmont Report. The Belmont Report literally guides us right now. Anyone who does human subject research has to do what? Go to the IRB, inform. All that is the legacy of the syphilis study. Okay, so beneficence, do no harm, respect for persons, autonomy, and here's the third principle: justice. The third principle is justice, and you know what it means? It says those who bear the burden of research should not be denied the benefit. Now let's turn that around. Those who bear the burden of disease should not be denied the benefit of the scientific breakthroughs we already have. Like, you can't go down to Guatemala, do a study, come up with a blockbuster drug, and make it only available in the Western industrialized countries. And the people who were the subjects can't even afford it. That's a violation of justice. So I think if we look at justice from the bioethics framework, it will also help us with our peers who have, in some ways, embraced, and our institutions who have embraced those bioethical principles, the principle of justice.
That's great, Dr. Thomas. And as we have less than 10 minutes, I want to make sure we address one question before I give everyone a 1-minute wrap up, parting shots to conclude this event. So we've discussed the idea of intentional partnerships, but a commitment of resources is equally important. We heard Michelle talk about Bristol Myers' commitment of $150 to $300 million. So as we have the ears of a diverse group, including those at Bristol Myers, give me one request, ask, or commitment that you would make if you held the purse strings that you think could advance health equity overall. So putting your money where your mouth is, what would you, and you can just give me one thing out there that you think would move this forward.
How much are we talking?
I mean, Bristol just said they got 300 million, so don't be shy.
So mine's going to be kind of more of a general comment, but I think we really need to invest more into our community-based organizations, and that also includes our faith-based organizations as a part of that, because that's who we leaned on, especially at the state level when we start talking about COVID and trying to get the outreach out there. So if we consistently add more, resources, monetarily and personnel and connections there, I think that's going to help us really connect to the communities in a better way. And they are the trusted messengers, the trusted sources within their own communities. So we need to go ahead and add more resources there so that we can have that connection and not have to reinvent this wheel every time there's a crisis.
Dr. Ruth,
Cornell, I say he took the words literally right out of my mouth. Thank you so much. It's exactly what I was going to say, is that, we're community-based organizations. We are boots in the ground. We're the gatekeepers. And we need the funding. Just yesterday, and I'm being very transparent, we had a board meeting yesterday, and we have X amount of dollars for programs because the grants that we have allows us to do the programming, but we don't have enough money for the salaries for the people to do the programming. And so we're up against that all the time. That is a constant battle. It was probably the one thing I don't like about nonprofit, but the work is wonderful. The work is great. We just want to be able to sustain that work and continue to caring for our community. But all honesty, it takes money and it takes staff. And again, those grants don't allow us to always pay for staffing. And that's a problem.
Ronnie, what do you think?
I would agree with that, and I would maybe take it one step further to say that that funding needs to go to supporting health systems and public health agencies in doing a better job in partnering with community-based organizations. But I think I would also say that, as I mentioned earlier, I think it's important that we look to the future and make sure that we have the structure in place to train that next generation of healthcare professionals and public health professionals to be prepared for I think about, as an example, I mean, just putting COVID aside and potentially the next pandemic, but just thinking about the aging of the US population and how 30 years from now, the estimates are that we will have tripled the number of Americans with Alzheimer's disease. We're not even close to being prepared for that. And so I think having uh, funds to support uh, the preparation of that next generation of highly trained healthcare professionals and public health professionals, I think, is so important.
And Ronnie, I'm in agreement with you. I would have said education and scholarship. So I'm with you. And I'm not saying that we have to decide it's one or nothing. I think there's a lot of room to make a difference or a splash in a lot of different areas. So I'm actually happy to hear that one. Dr. Thomas, I'll let you give us the last point before I give you guys. Now it's down to 30 seconds each.
Be very pragmatic, and I'll take it right from the lessons from the barbershop. Nobody wants to go back to normal, because going back to normal means living sicker and dying younger. Here's what I'd say to our friends at Bristol Myers Squibb. Hey, we need to help our community-based organizations be paper ready. So here's what happened during COVID. All this money comes down. Now they want to do a local church. The local church, they say, can we use your buses to get all these people to where they need to be? The church does it because the church serves the community, right? But you got to put gas in those buses. Well, the contract to the church is a cost reimbursement contract. They got to put the money out and wait for reimbursement. They're waiting 60, 90 days to be reimbursed. Some of the CBOs got in financial trouble. So they got a contract and they get in financial trouble, not paper ready. How can we help avoid that? That's an unintended consequence. How about a portion of those BMS dollars being in a health equity innovation fund? A health equity innovation fund that we can apply to with out of the box ideas. And how about leveraging corporate resources? BMS can keep its advertising money, but how about giving us access to the ad agency they have? They got a huge contract with the ad agency. How about giving us a little ad agency time so that we can produce our PSAs in a professional way? I think on the workforce side, a new workforce, I'll call it, for the sake of our discussion, the Health Equity Intelligence Service. We have the Epidemic Intelligence Service at the CDC, but Dr. Wright, in the barbershops, you're still Dr. Wright to me, Cornell. In the barbershops, we got the Community Intelligence Service. How about training them, certified community health workers, but they go through a Health Equity Intelligence Service training along with health professionals. They'll train together. And then last but not least, computer simulation. How can the new breakthroughs in artificial intelligence and computer simulation help be a new training platform for health professionals? Most medical schools have the simulated patient, the actor that comes in and says, oh, I got heart disease, and help you with your bedside manner. Let's animate that now in a computer simulation where we can really have measurable outcomes in changing hearts and minds as well as skills.
I love it. I love it. And that's going to count as your 30-second closure. So Ronnie, give us 30 seconds of closing comments from your perspective.
I'm just deeply honored to be a part of a wonderful panel, and this has been thank you, Dr. Keene, for leading this panel. I think oftentimes we get in a situation where it feels like we're like kids in a candy shop, where it's like there's all these things that sort of attract our attention. But I think we've had a really wonderful, focused discussion today, and hopefully this will just be the beginning of continued conversations, but also continued, resource allocation and really positive influence for the future.
Thank you, Dr. Bell. Dr. Ruth.
I'm gonna keep mine to 30 seconds because I pay attention, right? So listen, I'm going back to what I said earlier. When it comes to the community and advocating, listen. I can't think of what the I is, must be after lunch. Listen, investigate, follow up, and engage. That is life. When you're dealing with patients, when you're dealing with the community, when BMS, when you're dealing with your clients, when you're dealing with us, just think of life. Listen, investigate, follow up, and engage.
Thank you, Dr. Ruth. Cornell, you're the last of our panelists to give your 30-second parting shots.
I will try to keep it at 30 seconds, but first, Dr. King, I want to give you your props for just putting an amazing panel together and keeping me out of trouble. I have a friend named Pam Diggs, who I've known for years, who always calls out any panel, or and my also a good friend Vahisha Hassan out of Tennessee now, who always calls out if we don't have women, especially women of color, on a panel. And so I'm so glad you have kept me out of trouble from having to hear anything, because Dr. Ruth is amazing and has given us so much light. And I would love to see an all-women panel as a follow-up to this roundtable at some point. But I also want to leave you with this. We did a clinical research study with African-American men, recovering from prostate cancer surgery. And this was at Duke. And one of the men shared this with me, and I try to share this every time I speak, is that divine healing comes from divine direction to proper treatment. Again, divine healing comes from divine direction to proper treatment. We have the tools in front of us. We have the community. We have to make sure that we're not overlooking those divine tools that have that divine direction for us all to be healed. So thank you.
Excellent, excellent. So I would like to say thank you to this great panelists. You guys did an amazing job. This was a very stimulating. I'm sure we could go on for hours and hours, but in the interest of time, we can't do that. I would also like to thank the Bristol Myers team for the funds that help support this event and the coordination of all of that. And this has been wonderful. Thank you to all of the registrants and attendees for your participation in the chat and your listening. And we hope that everyone will take some of these jewels that were dropped today and really apply it to our jobs, to our communities, to our life. And thank you all again. And this has been amazing. Everyone have a great weekend, and stay safe and stay healthy.
Keep your mask closed and ask yourself who you're sharing air with. If you don't know, put the mask on. Bye-bye.
Dr. King, thank you so much.
My
Bye,
pleasure.
everyone.
Bye.